Back in the early 1800s, holistic medicine was very revolutionary. Person is a composite of body, mind, and spirit.
Essentially, what's the root cause?
People don't want to just not be sick or injured, but they also want to be healthier.
Because this is kind of like more of a proactive approach to healthcare rather than a reactive, because people are getting sick, they're coming in and they want medicine or they want things to, some sort of outward thing to help their internal things going on, right? But yours is more, what are we doing in the proactiveness of life?
Oh, you have high blood pressure, take this pill.
Yeah.
You have diabetes, take this pill.
Solving it with some external source.
What can we do to actually make it so that it doesn't happen again in the future or prevent it from even happening in the first place? There are other things that we can do besides medications and surgeries.
Welcome to the Healthcare Revolution podcast, where we empower you to take control of your health, build a community of trust in quality healthcare, and achieve lasting wellness. I'm your host, Brad Powell, doctor of physical therapy and owner of an award-winning clinic here in the Salt Lake Valley. Each episode, we dive into all things rehab, injury prevention, and overall health, bring you expert insights from leaders across various healthcare fields. Please note, while we strive to provide you with the best knowledge and advice, the opinions shared are those of our guests and should not replace professional medical advice. So let's revolutionize wellness and healthcare together. Today, I have with me Jared Aida, who is a DO, and he works at Alpine Orthopedic Specialists. And he is extremely talented. And what I love about Jared is he lives what he preaches. He's out in the community. He's got his mountain bike on his car right now. He's going scuba diving. He's got multiple plans. I just love it. But welcome to the podcast.
Great. It's good to be here. Thanks for having me.
Yeah, such a pleasure. I met Jared through Brandy, his girlfriend, and we decided we'd implant this just for her. Yeah. Maybe we'd give her a gift card if she heard it. What do you think about that?
I like it. We got to see if she actually listens to it.
Yeah, I mean, she might say she's going to listen to it, but you should better catch that. Well, give us a little intro about yourself. What is a DO versus an MD?
Yeah.
Give us that background.
Yeah. So unless you look at like your doctor's medical degree or what the initials are after their name on their white coat, you may not know the difference. There are two licensed medical degrees that have full privileges to practice in medicine or surgery in the United States, and that's the MD, which is the more common, and then the DO. The DO stands for Doctor of Osteopathic Medicine, and the DOs have been around basically since early 1800s. And basically the original kind of, as medicine has kind of evolved over the last 200 years, the differences are starting to minimize. But originally, back in the 1800s, MDs would had various treatments to treat different things, and it was very symptom-based, okay? It was very symptom-based. It was, what are your physical symptoms? And that is what we treat and diagnose according to what your symptoms are.
Yeah.
This gentleman called A.T. Still, he was an MD at the time, and he had the unfortunate tragedy of having part of his family contract illnesses, but then the things that the common day medical treatments for the day actually made their conditions worse. And so he got very disenchanted with that. And so he developed a system called osteopathy, which then evolved into osteopathic medicine, where it was a more holistic, whole person approach. This is not revolutionary now in 2025, but back in the early 1800s, holistic medicine was very revolutionary, where a person is a composite of body, mind, and spirit. And that was very revolutionary. And so DOs, as a result, would take a step back and look at, okay, what are your symptoms, but what else is going on with this person?
And essentially, what's the root cause?
Exactly.
What's actually, the symptoms are a presentation of something happening. It's just like a, check engine light going on a car. Like your engine light goes on, but what are the symptoms? What is the car doing? How do you diagnose the actual root cause? So I love the holistic approach. A lot of Americans are now starting to lean more towards that osteopathic, holistic approaches now. Are you seeing that in your clinical practice?
Yeah, I mean, a lot of people because people don't want to just be a constellation of symptoms anymore. They're like, what's going on with my life? What's my stress level like? What's my nutrition like? What's my stress? What's my, all those different things kind of make up your general health and well-being. And so people don't want to just not be sick or injured, but they also want to be healthier. And
Yeah.
so I think DOs, that resonates very well with the kind of DO osteopathic approach. And so they kind of like seeing DOs.
Yeah, tell us the difference between DO and PM&R. So PM&R is physical rehab and medicine, right? What's the difference between those?
It's just in terms of your medical education and training. So if you go to quote unquote medical school, you're either going to go to a medical school that grants the MD degree or you're going to get grants the DO degree. But then after that, then you have your what's called your residency training. So after medical school, like you're basically, you can be called doctor, but you have no real skills or skill set yet. And so then you go to do a residency. And so PM&R, which stands for Physical Medicine and Rehabilitation, was then my residency training after medical school. And so it focuses, and this is like probably one of the toughest questions, is like, where am I from and what is PM&R? Because I've lived all over the place, and PM&R is just, one PM&R doctor can look so very different from another PM&R doctor. But the way that I explained it to people is that basically the whole purpose, if you could distill it down, the one thing that ties all PM&R doctors together is a focus on function and maximizing function, whether that's pain or whether that's an injury or whether that's paralysis from a spinal cord injury or agitation from a traumatic brain injury or bladder issues from spinal cord injury or from a major neurologic surgery. They treat very different things, but we're all kind of trying to maximize
We kind of have this same, you could say, challenge in our profession as well. A lot of people say, well, I go to this physical therapist, it's very different than this physical therapist.
Mm-hmm.
And I think PM&Rs understand the same mindset that we have is function is really different for everyone. It has to be so customized, so unique. And that's why I think there's so much variation in practice. And there has to be similarities that tie us together as a profession.
Mm-hmm.
And ultimately it becomes function, right? Like, but what is it you need? Right.
Mm-hmm.
And there's so many complexities to just saying function,
Uh-huh.
you know, and that's why there can be so much variation as well.
Yeah.
You know, it becomes very complex.
It does.
So tell us, you know, why did you choose prevention, performance, and just quality of life, holistic approach versus other areas of medicine?
Yeah, I think it just started actually in college before I even entered medical school.
Because this is kind of like more of a proactive approach to healthcare rather than a reactive. Because people are getting sick, they're coming in, and they want medicine or they want things to some sort of outward thing to help their internal things going on, right? But yours is more, what are we doing in the proactiveness of life? Right? What are we doing on the front end to prevent disease?
Absolutely. Yeah. I'm a huge, huge fan of being proactive and kind of preventive medicine. But in college, I remember I was trying to decide whether I wanted to go to medical school. And I remember I got a little disenchanted there was like a crisis where I didn't know if I was going to go to medical school because I had a lot of doctors and they would just barely touch their patients. They would just prescribe medications or oh, you have high blood pressure, take this pill.
Yeah.
You have diabetes, take this pill.
Solving it with some external source. Yeah.
And it's kind of what we were talking about. They were just kind of like treating...
I don't want people to feel like we're bashing down. I think
not at all.
There's a place for it, right?
Yeah.
But you felt disconnected from that in some way.
Well, yeah, it's because it's like I wanted to kind of get to the heart of the issue. I mean, the heart of the issue is like, well, what are we doing to lose weight? What are we doing to exercise? Like, so that we're not reliant on like medications to treat our blood pressure. And so,
because essentially high blood pressure is an outward expression of something inwardly that's happening, and it's a symptom of something you may or may not be doing.
Yeah, absolutely.
Right? Like, how do we fix the root cause of the blood pressure in the first place before going to this medication?
Exactly. And so just that's where it stemmed from, is that like, okay, it's fun to do medicines or surgeries and whatnot, but what can we do to actually make it so that it doesn't happen again in the future or prevent it from even happening in the first place?
Yeah, absolutely. I love that. So how do we kind of make this, what's kind of your advice on making the shift in healthcare of the mindset of focusing on this holistic approach, fixing the root cause versus the symptoms. What's kind of your advice for, I mean, you think about the US, we're like the most unhealthy nation in the world, but we have the most resources, right? What are we missing? What's your advice to our community?
I think two things need to happen. One is from the patient side, they need to want it, which I was really excited to come on your podcast because there are other things that we can do besides medications and surgeries,
Yeah.
that we can do to solve this constellation of health issues. And so if there's a outcry from the patient saying, hey, this is no longer good enough, then the healthcare system will have to change. And so I think part of it is just educating patients, knowing like, hey, there's a better way. But secondly, just coming from the healthcare side is just knowing that we have to stop financially monetizing the quick and easy fixes. Because preventive medicine and being proactive, it requires patient education, patient ownership of their health and wellness.
Yeah, they stay in the driver's seat.
Yeah, exactly.
Yeah, and there's no reason for you to be in the back seat as me as the provider to be driving.
Exactly.
I'm not going to take control of your health.
Exactly.
You need to take it from the wheel and say, I'm doing something about this and I'm in control.
And the problem with the healthcare system is that as currently, they've tried to make some changes over the last decade, but still, the things that pay physicians and healthcare professionals the most are interventions, injection, surgeries, procedures, okay? Not taking 15, 20 minutes to sit down with your patient and educating them on how to effectively lose weight and keep weight off to improve your diabetes, your cholesterol, your high blood pressure, all those things. And so if I do that, there's no real way that I will lose money. And so whereas if I'm like, hey, if I just give you this pill, okay, your blood pressure's not great, increase it by this much, go on to the next patient. So it's more difficult.
It takes more time.
And unfortunately, as our healthcare system set up, we are not rewarded for taking the time to what I personally believe is better. So that needs to change.
I totally agree. I love that so much. You talked about sleep, you talked about nutrition, you talked about education. We don't need to go deep into each one, but talk to us before any kind of injections, procedures, stuff like that. What's the in between? We talk about this continuum, right? Of surgery is at the end, right? Should be the last resort. We should never be going to surgery unless we've done all this other stuff before. Because we want to keep your normal and natural tissues, and any good surgeon will tell you that, right? But we want you to start with all this conservative stuff first, because we know it's going to improve your quality of life, right? It's not that we just want you to start here because we're biased. It's saying, let's start with the most conservative things first, go through this process, and I promise you won't regret it along the way, because you've checked off all the boxes. And you end up needing surgery. That's appropriate too, as long as you've done everything in your power to do all this other things first. So I want to talk about this section that you're in charge of, that in between, before injections. What is it you're doing with your patients to generally educate them on?
So lifestyle interventions? Okay. Yeah. I love lifestyle interventions.
Lifestyle interventions. What are the things that you're educating people on changing your life? And I know every patient comes in with something different, whether it be diabetes or, maybe the biggest thing we deal with the baby boomers now is they've been in a profession that they're very active and they've never exercised in their life. They retire, and then what happened? Right? What do we got to educate them on? What are the things they need to know?
I'm a big fan of lifestyle medicine, which is a branch of preventive medicine. And
define lifestyle medicine for us.
Lifestyle medicine is basically 4 or 5 different concepts: physical fitness, nutrition, stress management, sleep, and emotional health and well-being and relation. Those are the classic 5 tenets of lifestyle medicine.
And this gets complex when a patient comes in. You're like, where do I start?
Yeah, absolutely. But it's just that's why taking a history and just developing that rapport with your patient is so impressive. Because, if someone comes in and they're in chronic pain and they are struggling because they just found out that they have breast cancer, and then their husband fell and is now hospitalized, and they're having other family issues, and then they're sleeping horribly and they're eating horribly, they can't exercise, their stress is out of control. They come in because they're like, I hurt. But all of a sudden, it's not just their pain. It is because all of those things are going to sink into how they perceive pain.
Mm-hmm.
And so now treating their pain or injury becomes not just a pain issue, but it becomes all of those things that you have to address in their life.
Yeah.
And it's more difficult and it's more time consuming. It's more rewarding, and you're going to like change your patient.
Yeah, I saw this meme the other day that was it was this long line of people, and it said surgery and medication, but there was this huge line of people.
Mm-hmm.
And then in lifestyle medicine, it was like one person.
Yeah.
And everyone's lined up for the quick fix.
Uh-huh.
But what about true change? What about real change? Things that are really going to matter in life. What are you doing every single day
Yeah.
to really create lifestyle change?
Yeah.
You know?
And not everyone, it's like lifestyle medicine, a lot of it's about motivational interviewing, because at the end of the day, like we talked about earlier, like there has to be a change from the patients. They have to want this, you know? They have to know about it first, but they have to want this. My toughest patients are the patients that don't want it, and they want the quick and easy fix. They just want the pill or the injection, and they don't want to change their lifestyle at all. Those are the ones that I struggle with, because then I have to put on my purely like pain management hat.
Yeah.
And they don't want to change their sleep or their stress or their fitness or their nutrition or their emotional health and relationship. And so those are the more kind of frustrating cases, is when they don't want to change, you know? But
yeah, they're sitting in your office, they're showing that they've arrived and they're asking for change, but they don't want to do the work.
exactly.
You know, and it's like, well, I just want the quick fix, you know? And I had this patient yesterday, poor gal, she's just had some chronic pelvic floor issues, and I start talking, she was severely malnourished, and we start talking about sleep and about caloric intake and protein, and she just wasn't getting better. And I said, can we talk about your nutrition? And she said straight up, I don't want to talk about it.
Yeah.
And I don't want to change that. I don't want to eat anymore. I'm fine with where I'm at, you know. And she's just skin and bones. Like, really, she weighed like 85 pounds in her 35 years old with 2 kids, and doesn't want to talk even about food, you know. And food is energy, right? And it's directly connected with pain. And, you know, with musculoskeletal pain, we see it change with treatment. But when we don't see it change with treatment, there's something else going on. And we need to address those things as well. But it's so hard. You know, we use this skill. You talked about motivational interviewing. Break that down for us. What does motivational interviewing mean to you?
Motivational interviewing. I mean, motivational interviewing, I am not great at it, full disclosure. I have been trained in it to a certain extent back in residency.
There's a whole book on it, man.
Oh, yeah.
We've all read the book, and it's challenging to do.
I mean, I feel like at the crux of it, you are basically just trying to like grab their hand, and just kind of, they're guiding it and they're making the decisions, and but you're just there to kind of probe and see where they're at. Are they ready to change? Are they
Pre-contemplation or contemplation?
Exactly.
Are they thinking about changes? Are they actually ready to change? You got to decide where on that continuum they are. And then where do we start?
Yeah.
Like, if you're just thinking about changing, well, here's some resources. Why don't you think about it? And then when you're ready for the next step, rather than saying, all right, here's what you need to do.
Yeah.
Right. Because we start jumping into treatment, but they're just thinking about change.
Exactly.
Then we're not going to go very far. So you got to decide where they are, which can take time, right? Which in healthcare, do we have all that time in the world? DOs have more time, PTs have more times, right? But we're still limited.
Yeah.
You know, we're still on a schedule. It can be challenging. Anything else you want to share about motivational interviewing that you found helpful in practice? And what our patients need to know about it too?
I mean, I think the biggest
It's not manipulation, that's for sure.
No, it's not manipulation. It's just like, at the end of the day, the patient this is what they have to want, you know? And if this is what they want, then they feel ownership of that decision, whatever they decide to do, whether that's just not eating after 9 p.m. or whether that's making huge lifestyle changes, but they have to feel that it's theirs, you know? And I feel like that is a big difference with the old school doctors and or healthcare professionals and the new school, where it's like, before it's like the doctors told you what to do. Now it's like more of a joint decision-making process, where it's like, hey, and I love educating my patients. That is the big thing. It's like, hey, like, these are our options, okay? And these are the risks, these are the benefits. I mean, if they ask my opinion or what I would do, but it's like, and when they decide, then they have ownership of it and they're more likely to do
It's
X
their
and Y
plan.
and Z. Exactly.
It's their plan. It's not yours. Like,
Exactly.
you're just laying out the options.
Mm-hmm.
It's like a menu.
Mm-hmm.
You know, it's like, here are the benefits of risks of each. What is it that you're drawn to the most?
Yeah.
And I will be a guide for that, right?
Exactly.
I love the thought process of the patient in the driver's seat, and they get to choose who's on the bus with them.
Mm-hmm.
It's like, you got this person on the bus, this person on the bus, and they're seeking out advice, but they're not giving the wheel to anyone,
Mm-hmm.
right? And nor as providers should we take the wheel from them,
Yeah.
right? I'm not driving this bus. This is your life. This is your body. I'm here to be a guide.
Exactly.
I'm here to help you navigate life, but it's your decision. Here are the options. I love that shift in healthcare, because we've gone so heavy from telling patients what to do, and now it should be about giving them options, right? So, anything else you want to add about lifestyle medicine that you focus on? I know it's super complex and there's so much variation with every patient.
We could have a podcast about the different components of like lifestyle medicine, but the biggest thing is that if you're looking to get healthier, fix something, like look at interventions, and if your healthcare professionals aren't good in it, then try to find someone else that is, because that I feel like is the best way to achieve greater health and wellness is what I would say.
And when you're looking for a doctor like this, at the end of their name, you'll see a DO, Doctor of Osteopath, right? Or Osteopathic. And, you just got to find providers that can help you, right?
Yeah.
But you think about that continuum that we've talked about, lifestyle medicine is at the forefront, right? People don't realize like, oh, I'm in pain because of my lack of sleep. My body is outwardly expressing something because I'm not getting the recovery or rest that I need, right? Getting 2 to 3 hours a night. You have pain. It's not that you need surgery on that shoulder. It's because you probably need more sleep.
Yeah.
Right?
Absolutely.
And same thing with nutrition. You could have a caloric deficit or a protein deficit, and you're trying to gain weight and your body's in pain, but it doesn't have the energy to supply the needs that you actually are required. So it manifested as pain, right? And there's multiple facets and layers to this that we can talk about. But ultimately, what we want people to understand is there's so much more than just surgery and, early intervention or researching things on your own. Lifestyle medicine, there's so much that you need to know, and getting an expert that can help figure out where you are and then figure out where you want to go, and then helping you build that bridge of your lack of knowledge. You don't realize how much you don't know.
Yeah. Oh, yeah. Absolutely.
Like, talk to me about how many years of school you had to go through to master your expertise. Like, how many years were you in school? Well, way too many, with residency and everything and the
9
fellowship.
plus.
Yeah, like you have mastered your craft. You're an absolute expert in these areas, right? People can't just go on ChatGPT and lifestyle medicine and figure out where I am, right? There's so many gaps to their education, what they know. And having a mentor or a guide can help collapse that time and help you really master where you're struggling.
Yeah.
But I love that you're big emphasis on lifestyle medicine. So let's talk about the next continuum.
Yes.
You get through lifestyle medicine and we've done everything in those roles and people are still in pain. Talk to me about the other things that you use in the clinic, whether it be ultrasound, diagnostic ultrasound, injections, non-surgical interventions that you use.
Yeah, there's so many. The first thing I would do is like activity modifications and the kind of lifestyle interventions. That's kind of like the first step we talk about. But a very quick second step is I would send them to you.
Yeah.
Send them to
what
physical
are things
therapy.
that you look at in a good physical therapist to kind of direct a patient to?
A big thing is I say you don't want a physical therapist that cookbooks you. Be like, oh, you got shoulder pain.
So lack of customization.
Lack of customization. No, every patient's different. Everyone has their muscle tension length relationships or posture, what have you. Everyone's a little bit different, And so a physical therapist that can do a good head-to-toe functional evaluation, looking at strength, mobility, flexibility, all those different things, and see where are the functional deficits.
Why do you find that key in your practice? Getting good PT involved in activity modification and pain reduction, improve a function? Why do you find that valuable in your practice?
I mean, because at the end of the day, when people come in with an injury or pain, my big question is this a structural issue, which then may require a procedure or surgery oftentimes, or if it's a functional issue, which means
If there's
that,
like a tear in a rotator cuff or a tear in a labrum or something like that.
Exactly, yeah.
Even with that, I mean, tears you can solve with therapy anyway.
That's exactly what I was going to say, is that like, I love sharing this
How
graphic.
bad is it?
Is that just because you have a abnormality on your imaging, that does not mean that it is causing the pain, And so that is
I've
a
had
big
degenerative
point.
disc disease since I was 12, and you're like, well, yeah, about 80% of people your age have degenerative disc disease. Yeah.
And so, but if I guess when I say it's a structural issue, it means that I am convinced now that it is the structural abnormality that is causing
your
pain.
pain. Yeah, absolutely.
But if a functional intervention, it means that, that means we have to change your function. Like we have to strengthen the posterior chain, stretch the anterior chain. You have decreased inflow rotation of your shoulder.
You might be tight in here and weak in here. Like just think about like a tire going down the road. The road creates an imbalance, right? And every once in a while you put some more weights on there to even it out, right? So whether it's a flexibility issue or a mobility issue or a strength issue, like our job is to maximize your ability to move.
Exactly.
Sometimes teach people to move differently.
No, that is exactly. And so that is the thing, is that when I send a patient to physical therapy, at the end of the day, like I don't want them to cookbook you, and I don't want them, the second thing I said, tell them, if I'm sending them to a physical therapist or they want to go to a PT that I don't know, I'm like, it shouldn't feel like a spa treatment, okay? If they put the moist heat pack on and then they massage you and then they put the TENS unit on and then do some gratuitous stretching for like 5 minutes or ultrasound, and it feels like so
You're working
great.
with an aide for 60 minutes
Yeah,
and you see the PT
it's like,
for
that
2.
is not like run over the other way. Like that is kind of very, very old school, I would say, physical therapy with a reliance on passive modalities. When I send someone to physical therapy,
and I think that's important, that what you say, the reliance, right? That, if you're going to a PT clinic and you're spending 30, 45 minutes on all these passive treatments, that is literally a waste of your time.
Yes.
Like it's getting you feel good, right? If you're spending 5 minutes on a heat pack on the end or, some electrical stimulation, it's a short period of time. The therapeutic effect for heat and electrical stim is 7 to 10 minutes, right? You do the feel good for a short period of time, but get moving.
Yes.
Spend time mastering your body and what it's doing, feeling it, learning how to listen to what your symptoms are telling you.
Absolutely.
That's what the majority of the time should be doing.
Oh yeah. I will explicitly put on pretty much every single one of my PT orders, modality should not exceed 50% of the visit time, because I'm like, guys, that's not why I'm sending you there. I want you to move differently.
Oh my gosh.
Because if you move differently, then your shoulder mates
PTs
feel
love
better.
that, because the thing is, we still to this day, believe it or not, we'll get PT orders from a physician that will say ultrasound, heat, and massage only.
What?
And I'm like, no, why?
No.
I'm like, dude, I respect you, but I'm not following that. I'm sorry.
Yeah.
And I'll reach out to that physician, but we are not doing that. That's not PT. And your job is not to prescribe what I'm doing. You know what I mean? Like, I got a doctoral level education in this. I'm not doing a full session of massage. I'm not a massage therapist.
Yeah.
Send them to a massage therapist if that's what you want.
Yes.
Right? Maybe go get some ultrasound, some of that placebo somewhere else, but that's not going to be this clinic.
Yes.
We are living a higher way of movement and the way that we're doing evaluation, treatment, customization, that it's not passive modalities. So I appreciate you saying that. That's great.
That is fantastic. And that's how it should be, folks. So
well, tell me about the after PT, like, they get back to you, maybe you send them to me, we've exhausted therapy.
Yes.
I say,
yes.
Hey, Dr. Aida, we're kind of getting the end of the road. We're not to where we need to be. It's not responding as anticipated with musculoskeletal injury. Let's talk about just diagnostic ultrasound. Say we had a hamstring strain, you're getting in there. What are the things you're looking for with diagnostic ultrasound?
Yeah, diagnostic ultrasound. So that basically means that, because Brad talked about like therapeutic ultrasound. That's when they like rub the ultrasound machine on your soft tissues for, 10, 15 minutes. Whereas diagnostic ultrasound, it's kind of what you're doing when pregnant women go to get their babies looked at. It's where we actually use the ultrasound to look at tissues in the body.
Mm-hmm.
And so I am a musculoskeletal specialist. And so I will be looking at shoulders, elbows, knees, wrists, and I can literally look at the tendons, the muscles, the ligaments, the cartilage interfaces, different tissues, and make diagnoses. And so we learned that the diagnostic ultrasound is an extension of the physical exam. And so it should be used as such. Never
Tell us
to
what that
replace it.
means. Yeah, dive into that a little bit, because you're saying that you have to understand the presentation first, right? Where they're struggling, the symptoms, and then you're using that diagnostic tool to see if it's married to the symptoms, right? Is that what you're saying?
Correct. Yes.
Because you could see something that doesn't match up with their presentation, right?
That is exactly right. And that's actually the kind of case I just saw just 2 days ago. A gentleman came in, a young, healthy guy, skiing accident. He's like in his mid-20s, and he had shoulder pain. And I did my exam, and he had a positive empty can test, which is a test that we look for like significant rotator cuff tears. And
yeah, it's just a quick test where you hold your arm out, we push down on it, right?
Yep, exactly.
And it's a has good validity. It's not excellent, but at least it gives you a starting point.
Exactly. And so I had my ultrasound next to him, and so I'm like, okay, well, let's look and see, kind of characterize how big this is. But I put the ultrasound probe on, scanned his rotator cuff tear, or scanned his rotator cuff, and he had the tiniest little tear ever. And so I'm like, okay, I change gears. I'm like, I don't think this is a rotator cuff tear.
Yeah,
I
because
think
the test is telling you, oh, that's a significant rotator cuff tear, right? But then you get it on a diagnostic ultrasound, it's like there's no, it's tiny.
Yeah,
and you're not going to say you're fine, but
exactly. And so, but he did have some bursitis, and so I'm like, I think that weakness of his rotator cuff was secondary to his pain and not from the rotator cuff tear.
Yeah.
And so just immediately I just changed directions with where the kind of diagnosis and treatment was going. And so it's a great tool.
Yeah, and it's quick. You got it in the office. Obviously, they're expensive devices, and you got in the training in it is extensive, right? You got to get a full-on residency in diagnostic imaging. If you ever seen one, up on a baby monitor, you're like, what are we looking at?
Oh yeah, it's just a bunch
I need
of
an
gray
arrow.
and white.
Give me an arrow sign. You know what I mean? Oh, that's a boy. Okay, yeah. But like when you're looking at a tendon or a cartilage, like the general public is not even going to know what you're looking at. It's like speaking French and you've never spoke the language before.
And they love it because it's like patients like immediate, like not patients. Everyone likes immediate gratification, and so when I'm scanning, I'm like, oh, you see that little black part in that gray area? They're like, yeah. I'm like, that's your tear. And they're like, okay, yeah. And they're like, it hurts when you roll over that area.
And now the symptoms with the diagnostic tool are equal or married in a sense.
Exactly.
And then you can say, therefore, your pain is here. It's matched up on diagnostic imaging. We're very certain that that's the cause of your pain.
Exactly. And then diagnostic ultrasound kind of ducktails into the point that you were talking about, is that when I direct an injection or an intervention, if I can't see it clearly with ultrasound, then I should not be going after it.
Yeah, I love that. So you're not going to just inject in the shoulder, like, it hurts here, right? But you don't know where the actual root cause is, right?
Exactly.
You're just treating the symptoms. But if you get on diagnostic ultrasound, you say, all right, that's what I'm targeting.
Exactly.
And then you'll use ultrasound guided injections, right? Tell me about that.
Yeah. So all of my procedures, all my injections are guided with some form of guidance. For the spine, it's typically with fluoroscopy, which is a form of X-ray. But everything else besides the spine, it's ultrasound guidance. And that's kind of like the new hot thing, not just in musculoskeletal and sports medicine, but in just medicine in general. They're looking at your lungs, your heart. You're looking at different parts of the body, obviously babies, but it is, they joke that the ultrasound probe is now the stethoscope of the new generation of physicians. Yeah. And so it is becoming an increasingly popular diagnostic tool. But yeah, I guide all my interventions, and there's tons of research that shows that using ultrasound guidance for your injections is more accurate. So why not be more accurate.
If you know the problem, we're going to target that problem. We're going to watch the needle go right into it.
Exactly.
It's so awesome. And you
Exactly.
can use those tools to change people's pain really quickly.
Mm-hmm.
And that's was something that we love to do in practice, especially when we're not making progress as we would anticipate. You know, we're 3-4 visits in. It's like, this isn't responding how a typical rotator cuff tendonitis is typically responding, right? And we can get them back to you, and you could throw up, you know, that ultrasound and say, okay, let's get an injection in there. Or, you know, we could say, yeah, let's give it a little more time.
Mm-hmm.
But ultimately, like when we get stuck and we can't get anywhere, it's hard to move.
Yeah.
It's nice to get them into you and say, okay, maybe we get another intervention, right? You might do that injection to calm it down, and then we can get back after moving it and strengthening that rotator cuff. But I love using each other as a team to help expedite the healing process. You know, it's key because people stay in pain for a long period of time. It changes a lot of things in the brain. You know, the brain just can really remap itself and stay in chronic pain for longer, and it can be really hard to manage at that point. So let's just kind of talk about key takeaways from our podcast. You know, we talked about, you know, this continuum of most, you know, the least invasive to most invasive continuum. We talked about lifestyle medicine. What are kind of the key takeaways our listeners are going to get from this podcast? What advice do you have for them on everything that we've covered?
I think it's important to know that conservative treatment makes up the majority of the spectrum of treating like at least musculoskeletal conditions.
80%.
Yeah. Like surgery
you should
is
spend most of your time here.
that much.
Yeah.
Okay.
And I think our surgical colleagues would agree as well, right? Like they should be the last resort.
Yes.
You know, let's do all this stuff first, not to waste your time, but literally just to improve your quality of life.
Yeah. The other thing I'd say is that conservative treatment or non-surgical treatment is not just a steroid injection and physical therapy. Okay. I mean, the first thing I'll say with physical therapy, I'm like, well, were they treating the right thing? Okay. If they're treating the back,
Did we
and
diagnose
you've got
it right?
hip issues, then it may not get better.
Yeah, that
And-
might say PT didn't work. And you're like, okay, let's
Exactly.
dive into more of that. What does that mean?
Yeah.
You know, where's your pain? You know, where did they treat? How did they treat it?
Yeah. Were you doing the homework, the home exercises I gave you?
I just went to therapy twice a week and I didn't get better. It's like, well, did you do what they said?
Exactly. And did you go to like 3 to 4 visits, or did you go to like 16 to 20 visits? You know, and so it's just like, did you have a good physical therapist? You know, not all physical therapists are created equal. And so there's so many different things that go into it. It's not just a steroid injection or cortisone injection in PT. There is so many different things that we can do. I mean, there are percutaneous tenotomies, there's nerve procedures, spinal cord stimulators, there's sprint peripheral nerve stimulators, peripheral nerve stimulators. There is PRP, there's prolotherapy, there's hyaluronic acid injections. I mean,
the list goes
so many
on and on,
options, out there.
And so many people just skip all this stuff.
Uh-huh.
And then once you change the natural tissues, there's no going back.
There's no going back. There's nothing worse than where it's like a surgeon has done a major surgery. They're like, they still have knee pain after knee replacement. I'm like, well, now you've completely altered the normal anatomy.
And now we're going to be treating something totally different.
Yeah.
And it's so hard to change at that point.
Very difficult.
But let's look into all of these options before, and having an expert that can guide you through that process and give you your options is so important. So I love all these treatment options. So what's kind of the next thing in healthcare? Like, where are we going next? You know, you're young in your career. You're coming in with a lot of energy. Where do you hope healthcare goes next?
Just in general, or like pertaining to my specialty?
Let's talk about your specialty and then in general as well.
Yeah,
we'll kind of wrap up
absolutely.
with this last conversation.
Absolutely, yeah. In my specialty, sports, spine, musculoskeletal medicine, it's all about targeted interventions. Whereas before, I mean, people are most familiar with like cortisone or steroid injections. And the way that we liken that is it's like an atom bomb, okay? Like even if you miss the target, in all reality, it may help because it's just going to like decrease pain and inflammation all over the place. There's studies that support
Just get
this.
you an oral steroid, you'll be fine.
Whereas now they've got things called orthobiologics, which, PRP, stem cells, what have you. And the research still needs to develop, but those are more like a smart bomb. where
And PRP, plasma-rich injections, right?
platelet-rich plasma.
Platelet.
Platelet-rich plasma.
So you're essentially taking their platelets and injecting it into the area that's painful, and it creates that the body's healing itself response.
Exactly. You're basically hijacking the body's kind of natural healing system and the inflammatory system to try to help an area. And if you miss with PRP, if the smart bomb misses, then it's not going to help. So it's a very targeted intervention, but that is kind of where things are going with my field, is that more targeted interventions. It's not just steroid injections.
Where do you think healthcare should go in general in the United States? Like, where do you think our shift should be? This is the healthcare revolution.
Yeah.
What are we trying to change?
I mean, I think we just go back to how we started the podcast, in that there just needs to be a fundamental change in making people healthier. We're very good in the United States and in westernized medicine, at providing life-saving treatment with averting the crisis, keeping people alive. What we're not good at is making people healthier. So it's like, yes, they did not die from a heart attack or from a stroke. They had this major brain surgery or orthopedic surgery. But now what do we do? Like, how can we make these people now not sick people, healthy people?
Mm-hmm.
And I feel like people are getting more interested with their health and their wellness, and they want to be healthier, not just not sick.
Mm-hmm.
And so I feel like that is kind of what I feel like needs to happen with the healthcare system. And if we do that, I mean, we're going to have healthier, happier citizens.
And what a better person to seek advice from than someone that's doing it, right? I mean, you're living that life.
Uh-huh.
You are out active every weekend doing something. I follow you on social media. I'm like, that guy is active. You guys are constantly, snowshoeing, skiing, mountain biking, scuba diving. Like, you're doing all the things, right? You're living what you're teaching your patients.
Mm-hmm.
And I think that's something that we all need to realize as well. If you're not living it as a provider, you need to start, right? You cannot be prescribing something you're not doing yourself.
That's true.
Like, you shouldn't be. You should be living your life and leading it. Be the example. That's where we should be, leading from the front, showing what society looks like. If you don't know what success looks like, how are you going to help your patients be guided through that, right?
Mm-hmm.
If you don't care, I had a mentor tell me the other day, like, don't take advice from anyone that doesn't care about you, that hasn't been there before, and demonstrate what success looks like. And that doesn't mean that you can't, learn something from everyone. But ultimately, like, if I don't want to trade shoes with you, why would I take advice from you?
Yeah, 100%.
Or ask advice from you, right? Mm-hmm. And like, when you're looking for a provider, look at their lifestyle. What are they doing? Are they living what they're saying? Or is it coming as a hypocritical statement?
Mm-hmm.
It's like, stop drinking energy drinks, but I got an energy drink on the table.
Yeah.
It's like, okay, well, you're giving me a mixed message here. Which one should I follow? Right? But find providers that are living that life. And as providers, let's lead from the front. Let's show society what lifestyle medicine's really about, and how to prevent disease and all these things. Like, 90% of the stuff that we have in healthcare is all self-inflicted. There's so much we can change. There's so much we can do. So I love your message about lifestyle medicine. So awesome. We should spend 80%, 90% of our time, maybe 95% of our time in conservative care. And then that 5% at the end when it's absolutely necessary. Any other concluding thoughts as we wrap up?
I would just say, stay moving. That's the big thing.
Get out there. Yeah.
Get out there, stay moving, and do a variety of different movements. A lot of the stuff I see is overuse injuries. It's people doing the same exact thing
over and over
day
and over.
in, day out. It's like, oh, you want to go for like a 3-mile jog? Great. But maybe like try to integrate some
switch it up,
swimming or some cycling or a different sport, because the body loves to move, and bad things happen when your body stops moving.
So much of society, we're sitting at computers all day long, and then we go work out for 1 hour out of 24, and we think that's going to reverse everything, right? But ultimately, our bodies are meant to move. And I love 100%. What you do. Like, you're doing a variety of movement, right? You want to reduce injury more than anything else in the world. The number one thing you can do is variety of movement.
Absolutely.
Do different sports. Don't do the same thing.
Cross-train.
Yeah, cross-training is key. Accessory work, like strength training, doing all different things. So your body gets a ton of variation, and it develops and adapts based on those demands. And those overuse injuries come from too much demand that the body can't, produce. And that supply and demand has to be, equal. So thank you for coming on the podcast today. We appreciate
pleasure.
what you do, and so much what you do for the community. And we, where can people find you if they need to find you?
You can find me online, Jared Aida. I'm at Alpine Orthopedic Specialist in kind of Mill Creek area of Salt Lake City. And yeah, would love to see you.
Changing healthcare. I love it. Well, thanks again for joining us.
My pleasure. Good to be here.